Well, first thing to say, well done. Everybody's been involved. Fantastic. End of another week, particularly doing the work that you're doing, which is absolutely fantastic. Remember, this is one of our work streams. We've got 3 work streams. We started with Judy Mason, or we started to do the work with Judy Mason back in September. So this is the second of the WRIP, right? So you've done a great job in terms of coming together this week. It's one of 3 work streams. Okay, so this is still a cardiology work stream focused on patient flow and discharges. So we're looking forward to hearing the report out today, but I think absolutely fantastic. What I like is the enthusiasm that generates around it. When we were together with folks earlier on in the week, it was really, really interesting talking to some of the cardiologists about the discharge process, which actually you hadn't realised it was so complex. And we've added layers of complexity that we kind of need to unpick. So really looking forward to hearing what you've got to say today, but really genuinely very, very well done to all of you, because I think the outputs have been fantastic, at least what I've seen so far.
Thank you. Thanks, Michael. So, thank you for coming this afternoon. We have been running a 5-day rapid process improvement workshop looking specifically at cardiology discharges from Homewood. So we had a team of 9 people through the week, including a consultant cardiologist, therapists, pharmacy input, nurses from both Homewood and the discharge unit, a ward clerk, and we've had 2 representatives of patients and carers who have been absolutely critical in saying this doesn't feel right or this does feel right for us as potential patients. In addition to that, we've had an advisory team, and we've accessed that advisory team this week. So we've spoken to Nikki Berry around portering, or portering, Andrea in dispensing around how the dispensing process works, and also Sarah Reeves in transport, so thinking around what the transport implications are from discharge. So having access to that advisory team has been really critical in getting that work forward. So we had a project plan with all of the issues that we wanted to address during the week. So as you can see, they were numerous, and we're going to share with you now some of the work that we've done during the week.
Okay, so my name's Alana, and I've been team leader for the Rapid Process Improvement Workshop this week. We've spent the last 6 weeks collecting metrics, timed observations in Homewood and in pharmacy. We've realised that we have a discharge tact time, or total tact time of 150 minutes. A tact time, if we're going to discharge patients between 8 in the morning and 6 at night, that gives us 600 minutes per day. We have 4 patients to discharge per day from Homewood, which means the pace of the patient being discharged is 150 minutes. The range of metrics is also included looking at the number of patients who are medically ready for discharge per day, patients knowing their ED, their estimated date of discharge, or expected date of discharge prior to the day that they're going home, which was 50%. And we also did some measures around staff satisfaction, and tellingly on the Homewood ward and CCU, we discovered that around 50% of the staff actually found the discharge process confusing and frustrating.
Hi, I'm Sarah Butterfield. I'm a student at Manchester Business School, and I've been observing this week and offering a patient perspective. So this is the current patient value stream, and it's timed from the moment that the decision is made that the patient is ready to discharge to when the patient either leaves the cardiology bed or leaves the discharge unit, depending on their pathway. So as you can see at the moment, from the decision to discharge to the discharge summary actually being completed, there's currently a wait of 75 minutes. And then once the discharge summary is completed, to the TTOs being screened, there's a 17-minute wait. So due to these waits and the current cycle times of each step, total lead time of this process is currently 4 hours, 10 minutes and 53 seconds, which is 250 minutes and 53 seconds. Of this time, only 47 minutes and 30 seconds are value added for the patient. This means only 19% of the total lead time is currently actually value adding for the patient, and this week we've been looking at ways of increasing this percentage.
Hi, I'm Kate. I'm one of the sisters on Homewood and CCU. This week we've been involved in the process, or we've been looking at the process in which patients are currently being discharged from home in CCU. And we actually found that there's no standardised format in which patients are reviewed in the morning prior to the ward round. That is the patients who may be acutely unwell and then the potential and definite discharges. We felt that communication between the nursing teams, doctors, therapists took place at different times in the morning instead of an MDT with everybody involved. We have therefore trialled a bed board at 8 AM, which is 20 minutes long, which is concentrating on the day's potential and definite discharges and reviewing the patient acuity and setting EDDs for all patients. The bed board is consultant-led and it involves the nurse in charge, occupational therapist, physiotherapist and pharmacist. Patients who are for discharge on that day are reviewed by the consultant, and this is to aid early discharge and to shorten the current discharge time, lead time. I have written a standard process description form which outlines the bed board. We have also looked at a visual aid for the members for everybody post our bed board meeting, and this is to be trialled and displayed on our MDT door, so that it's a quick visual aid for all parts of our MDT, and that is definite discharges, and it's basically just a tick box, so a quick visual aid.
I'm David, I'm the Chief Pharmacist, waved across here, and I'm the co-process owner for this process we've been looking at. The value stream map that you see over here showed that the discharge process started too late in the patient's admission, and that we need to move the writing of the discharge letter, screening, dispensing and transport back to the ward earlier in the process, actually to the day before discharge. So if we can do that, we'll make some significant gains. There is a risk of some over-processing with late changes, but we think that particularly changes to TKOs, but we think that the net gain in efficiency is so much greater than any loss that it's worth trying and measuring the impact. In fact, the junior doctors told us that they usually write the discharge letters the day before, but they don't release them for screening. So we're trying to get that put right with help from the whole team. We identified some other potential delays in the way that discharge letters are written, and with having long lists of medicines that the patient came in pre-admission. But the consultants told us that they actually use those at the post-discharge review in outpatients, and so we're going to stick with those. There were a couple of other problems with layout in the pharmacy, such as where a printer is, and so we couldn't solve that in the first 5 days, but we're going to get that solved over the next few weeks.
Hello, my name is Jane Ritchie, and during our workshop I've been representing the view of the patient and carer. Looking at the workflow of the discharge system, it was immediately obvious that timely delivery of TTOs from pharmacy to the wards is necessary for speedy discharge. Currently there are delivery rounds by the porters, the earliest at 12:30, has meant that patients are often ready to go home before their TTOs reach the ward. A trial started yesterday that has been named Little and Often. The first porter delivery is now 11 AM and more will follow at short and regular intervals throughout the day. This will help TTOs be ready on the ward before the patients are ready to leave. The results will be happy patients and carers and happy staff who will have had to make fewer phone calls chasing TTOs and often resorting to collecting themselves. A further benefit for the hospital is that 2 of the additional porters' rounds will include collection of pathology samples from the wards.
Hello, my name is Rebecca. I am an occupational therapist, and on Monday we were introduced to the 5S system, which stands for Sort, Simplify, Sweep, Standardise and Self-Discipline. We went on to the wards to establish how this can be implemented on home ward, CCU, pharmacy and the discharge unit. Photos were taken of the stock in the cupboards on the ward to make it easier for staff, including the ward and agency, to identify where essential items are and which can be crucial in an emergency situation. We also looked at tidying up areas where staff property is kept because it is currently unsafe and not secure and takes up a lot of space in the MDT office. Within the self-discipline element, it will be down to the staff to maintain good standard practice, which can be achieved with our team empowering staff on the ward. Ultimately, we'll be looking after the patients and their experience and also looking after the staff and their environment.
Hello everyone, my name is Lisa and I am the sister of the discharge unit at East Surrey Hospital. As part of the RPIW, I reviewed the current discharge checklist in use at the moment in the discharge unit. This checklist was found to be outdated and provides limited information regarding key elements of a safe discharge. A new version has been developed, which has been trialled this week in the discharge unit. It includes vital questions such as, does the patient have a key, type of transport booked, equipment needed, and drugs to take home information. All key elements of information are required to facilitate a safe discharge and reduction of lead time and reduced need for costly couriers. Another focus from the RPIW has been to look at the use of hospital transport. Transport currently is overused by patients. As part of this process, by identifying patients with potential and actual discharges at bed board meetings at 8 AM, transport can be alleviated by friends and family. All transport can be pre-booked a day in advance for the morning, reducing the number of afternoon discharges and releasing beds earlier in the morning on Holmwood and CCU. Also, from meeting with Zara Reeves, the message of the Age Concern Take Home and Settle service will be redistributed by format of the transport newsletter, which is available to all staff. Not only will this assist in discharge of patients, but it will also ensure a better patient experience at the point of discharge.
Hello, my name is Holly. I'm a staff nurse on Holmwood and CCU. So the past week we've also focused on patient information and communication and creating a patient-led discharge. Although there is a current patient leaflet for planning of discharge, staff are not necessarily aware of using the communication aid. We felt that a patient discharge checklist would be visual for patients and their relatives to keep them at the focus of discharge planning. This would include admission date, expected date of discharge, asking if the patient had a care package prior to coming into hospital, if they require hospital transport, and asking if the patient is discharge summary mapped leaflet was explained by the nurse. We hope this will empower patients to be more involved in their own care and give them a sense of walking away knowing that what should have happened has. The care package question will initiate early recognition of therapy needs to reduce discharge delay and ensure patients go home with all required documentation. This is going to be some further work streams led with Jane Griffiths to merge the checklist with the current patient leaflet and standardise this communication tool so it is used by all staff. We are currently trialling this checklist on Holmwood Ward and incorporating it into our admission paperwork.
My name is Matthew, I'm the ecological consultant, and as you know probably better than I realised before, discharge is a complex process and involves multiple steps and a coordination of multiple teams to be effective. And something which is supposed to be a happy event for the patient going home quite often tends to be a negative experience because the long waiting time between the actual patient being declared fit to go home and actually physically leaving the hospital premises. At the moment, as you heard, it takes about 4 hours from the time when we, as a consultant, decide the patient can go home and actually leaving the hospital, and that causes a lot of anxiety for the patient relatives and also puts a lot of stress on the staff. So we took a very ambitious plan to cut down this time to 2 hours. And to be able to do that, we have to implement a lot of work actually the day before the patient going to be discharged. How are we going to do it? So we have to plan for the discharge on the day of admissions. So by putting estimated discharge day on the consultant and post-take quadrants, and then by updating this discharge day on our morning quadrants, as you heard, we've got multidisciplinary teams attending. And then by identifying patients who are going home on the day and then actually prioritizing to seeing them earlier. And in the previous pathway, there was a lot of work happening, but the patient were not aware of that. So what we're doing now, we have multiple touchpoints with the patient and the patient leaflet. By this, involving them and explaining them what's actually happening will improve the patient's satisfaction and experience.
So we're aware that this week there was unusual activity within the hospital with the industrial action. However, we did have a couple of patients that we did achieve their discharge within the target set by our sponsor. So we had a patient who left the cardiology bed from decision to discharge within 55 minutes, which shows that was a 58% improvement on our baseline. We had another patient who left the hospital within 2 hours of a decision to discharge, which is a 53% improvement on our baseline. And as you've heard, we're going to continue to trial these improvements and test them out. We'll monitor them, continue to do our try and do study act cycles, and we'll check them back in 30, 60, and 90 days.
So, as I should have said, I was the co-process owner at the start as well, which I didn't say, I'm very sorry. So, next steps. As you can see, all 3 areas have got plans and trials and audits to do so that we can trial and see if this process can be, as my colleagues have said, more patient-led and to keep the patient in the loop. I think that's quite important through the whole discharge process. There will be a 30, 60 and 90-day rollout, and we've got quite a bit of work to do with our aid consultants as the work around it, maybe possibly protecting time for our PA to do some discharge papers the day before discharge.
But we feel as though we've made some massive achievements, but we've learned lots as well. So some of our key learning points are that change is difficult. It's really difficult, and we've tried to do some really small changes, but even though we've got people working from the teams that do the work on a day-to-day basis, when they go back and speak to other team members, they've got different ideas. So just that whole communication process between the RPIW team and the home team is really challenging to manage. We did learn that small changes can have a big impact. So some of the things that we've presented just seem like really tiny things, but that visual aid of the number of discharges they're actually going today on the door, which the site team can see, which the nursing bay staff can see, which the MDT room can see, we think it's going to make a big impact in terms of knowing visual aid. We know which beds, we know which patients are going today. And we also learned that we've been through a really structured process. This is our second RPIW, but it works. It works in terms of generating the ideas and testing out those ideas actually here in the here and now and with patients in the clinical areas. And our last learning point was that David is really rubbish at making paper planes and he needs to stick to drugs. We also want to, there's hundreds of thank yous. So this week can only have happened because we had an open house. We had over 35 people to our open house. And the teams that this team have been working with out in the discharge unit and quarters, in Homewood and in pharmacy, we couldn't have done any of this without them. So we've got lots of acknowledgements and thank you to people that have really made a difference to our work this week. Thank you.
Good afternoon. I'm Keith Middleton. I'm matron for cardiology, and for this week I've been the sponsor. And my role as sponsor was to set the challenge. But I think one really important thing to remember is that there is an inherent challenge with SASH Plus and Virginia Mason, and that is that everything we do must be focused on the patient. So every change we make, every resource we deploy has got to improve the quality of the patient's journey and has got to enable them to participate in their journey. My challenges, as already been alluded to, were to halve the lead times, so to halve the time between decision to discharge and leaving the cardiology bed. And 2 examples already this week, in a very difficult week, operationally and with the doctor's strike. 2 patients have left their bed within 55 minutes, which is brilliant. I'd ask you to imagine a world where that process flows throughout the trust. So I really look forward to the report outs of 30, 60 and 90 days. I'm sure we're going to see some significant improvements throughout the trust as a result of this week. And finally, if you haven't had a look at the work that these guys have done, do take the opportunity before you leave. And lastly, can we put our hands together and say thank you to that team?
My name's Rhonda Stewart. I come from Virginia Mason in Seattle, Washington, which I'm going back to tomorrow. I will be back in a month for another RPIW in the outpatient area. I'm assuming recording out here again, so come again. I just want to make a couple comments about the week. I've been with the team the entire week. My role is to coach the team leader and workshop leader and get them certified. My role is to help guide the team and make sure that they're going in the right direction. A couple of things I want to comment on. At the beginning of the week, one of the team members said that, made a comment about the discharge lounge is like an airport, and people just want to go, take off and go home, right? And that's the feeling in the discharge lounge. Why can't I just go home? Everything about me is clinically ready to go home, and home is ready to take me, and why can't I go? And so how do we build that urgency of getting these patients home? And I think the theme of this event was really around standard work and the standard sequence. So how do we sequence our work in an order that will cause everything to come into play at the right time? How do we make sure those TTOs are coming into play at the right time and that's not the last thing we're waiting for? Because the pharmacy handles those really quickly when they get when they're ready to be processed. But if they don't get them till later, it's not going to happen quickly. The porters, with every intention, you know, what works for them? Going up and across, but the discharge unit is the farthest unit from the pharmacy. Think about that. And yet that's the meds that we need to get these patients out the door. There's all the meds that also need to be delivered to the rest of the hospital. But I like this little and often rounds, right? It's small batch size. When you batch, if you have a batch of 50, that first item in the batch waits until all other 49 items are processed. Right? So think about being that 50th patient with your 50th prescription, ready to go home, but you're at the bottom of this cart with all of these prescriptions on there. The other thing about standard sequence really has to do with the ward rounds, and so making it important that we do the discharge patients first. But why would we do that? They're healthy. We want to get to the more critical patients first. Well, yes, we want to do the critical ones first, but then there's the patients that are going to be here for a couple more days, and we have patients who want to go home. They just want to leave and they're ready to leave. So there was a comment about Bay 8 being the 8th bay, and so it was the last bay that was worked on. I would hate to be the patient in Bay 8 that wants to go home, because you know your rounds probably won't happen until noon or just before noon. And so how do we reprioritize for the patient and putting the patients first, but not compromising for the other patients? The other thing I wanted to talk about was communication and handoff, and I think that was really important here, is getting a team together who've never worked together, and so much communication happening. And now writing down, we learned that writing something down makes it real. We can talk about it all we want in the conference room, but until it's written down, documented, hanging on the wall, standard work is written, our agenda for the bed board in the morning. The first time we tried it, we didn't really have an agenda. Second time, we had an agenda. Third time, we now have a visual that says, and here's your deliverables. After this is why we had this meeting. And lastly, this the follow-up work. And so it's really up to that leader. It's the leader that needs to make sure that this work is sustained. So I know Kate and Dave are both up to the challenge, as well as Lisa, to make sure that this work sustains in their department. And if they're not paying attention to it, and they don't pay attention to making sure that the bed board meeting in the morning actually resulted in a talk about discharge and some EDDs being logged. If that doesn't happen and they don't pay attention to that, everything will go back to the way it was before. And so the leader's role is really critical. So thank you very much, and Michael is going to close us out.
Well, what a fantastic week. I suppose what I'd like to say to the team is a really, really big thank you for the energy and fantastic work that's been done. It's really, really great. When I think about the work that we're doing, it's about four things for me, really. It's a bit more than that, but it's about improving patient experience, improving quality, safety, clinical outcomes. We do that by reducing variation, okay? And ultimately, we reduce waste and we reduce costs. So I want us to think about that in those terms. Most of all, what I want you to do, really, is to go away and do this without seeking permission, because that's the most important thing. Okay? And it's really important that you now take charge, okay? You go forward and you implement this, okay? We're here to help in the background, to support people, okay? But really, really important that we keep the momentum going and we drive this forward, because we will see, as we stick at it and we develop new tools and new skills, we will see improvements in those 4 areas I've talked to. Now, there's a few other things, of course. There are more taster sessions, so if you want to know more, then come to those. And if you want to do the Lead to Leaders programme, there's still places left, and the closing date for that is Wednesday next week. So thanks very much, folks, and remember, you don't need to seek permission, okay? Have a good weekend.